We say that, and again, I'm putting biliopancreatic diversion, duodenal switch, two operations together. You have to ask the question, perfect for what? Perfect for weight loss? Perfect for lasting weight loss? Perfect for comorbidities resolution? Perfect for safety? Late complications? Cost? Life expectancy improvement? Patient satisfaction? Now, let's look at the literature and what we can see about these items. First of all, weight loss. This is a meta-analysis that we published in JAMA in 2004. And in terms of weight loss, and these were a lot of patients in this study, banding was 47%, gastric bypass 61%, gastroplasty 68%, and biliopancreatic diversion duodenal 70%. So it causes the greatest weight loss. All right, let's say lasting weight loss. Here's a paper by Dr. Scopinaro, and he showed at 10 years that 90% of patients with a N of 1,120 patients had greater than a 50% initial extra body weight loss. And at 18 years, 70%, 871 patients, had 77% loss of excess body weight, which was similar to the 72% at 2 years. So once again, biliopancreatic diversion duodenal switch has the greatest weight loss and the most lasting weight loss. Comorbidities resolution. Going back to the 2004 meta-analysis, if we look at the hyperlipidemias, break them up according to the different procedures, banding 58%, gastroplasty 76%, gastric bypass 96%, but biliopancreatic diversion duodenal switch 99.1%. And now here is a paper, another meta-analysis that we published in 2009 in the American Journal of Medicine. And we looked specifically at diabetes. And you can see that as the weight loss increases from banding to gastroplasty to gastric bypass to biliopancreatic diversion duodenal switch, the resolution of type 2 diabetes increases as well and ends up with 95.1% for biliopancreatic diversion duodenal switch. And you can see that these results were present before 2 years and identically after 2 years. So as Dr. Scopinaro has just so nicely shown, these results on type 2 diabetes are lasting. All right, now here is another paper from Dr. Scopinaro, a recent paper, in the Annals of Surgery, 2011. And he has shown these results, but they certainly should be repeated. 25 to 35 BMI without causing excess weight loss. I'm certain that when Dr. Scopinaro started this series, everybody said, you're going to kill these people. They're not heavy enough to have a biliopancreatic diversion duodenal switch. As a side story, in the United States, the people who really know what operation we should do are the insurance carriers, because they dictate to us very often what we should do. In other words, if I would put in somebody with a BMI of 35 for a duodenal switch, they would come back and say, a patient isn't heavy enough. You have to do a gastric bypass. But in that kind of a mentality, Dr. Scopinaro had the courage to do it. And what happened? They didn't lose that much weight. They lost a little weight, but they lost their diabetes. Safety. 30-day mortality, which is considered Operative mortality, here's another meta-analysis that we published in Surgery in 2007. The operative mortality at that time was higher in biliopancreatic diversion duodenal switch, 1.1%, which is not very high, except for those unfortunate individuals who belong to that 1.1%, but it was higher than the purely restrictive or gastric bypass. Since then, there have been other studies. Mortality has gone down, and a month or so ago, we looked at our records at the University of Minnesota. We have now done 367 consecutive duodenal switches, and we've had no mortality. Late complications. Again, looking at our series, we've had hypoalbuminemia and or early liver failure in less than 2% of patients, and they've all been rescued by reoperating and adding a segment of small intestine. Again, we've had no late mortality, and we've had no late liver failure. We've caught these things early, usually before liver failure, low protein, and have done something about it. But the overall percentage is extremely low. Cost. Well, I have no particular cost breakdown, but if we look at the Sampalis paper, which you're familiar with, at about 4 years, the cost of doing surgery is less than the cost of not doing surgery. And here is the paper by Premier that I had the privilege of being on, and he's an economist and a mathematician, and we express this in a return on investment, and at about 50, 60 months, you're going to return on investment by doing bariatric surgery. But I'm willing to grant that the initial cost of doing a duodenal switch may be higher than doing a band or a gastric bypass. Life expectancy improvement. Paper by Christo, again doesn't single out biliopancreatic diversion duodenal switch, but again you can see that within 5 years you get a statistically significant increase in life expectancy. Patient satisfaction is a very difficult thing to say what patient satisfaction is all about, but we're convinced, the 4 of us in our group at the University of Minnesota, that the people having the DS are happier than any of the other patients, because we do bands, we do gastric bypasses, we do sleeve gastrectomies, we do experimental procedures, but our DS patients are the happiest, because from a day-to-day basis, they have the least complications. They can eat more. They can eat more than they can with a band, for certain. And they live a closer to normal life. So I put all this together in a hypothetical table, and I've ranked weight loss, documented, the best is the DS. Lasting weight loss, documented, the best is the DS. This is medical therapy, worst. Comorbidities resolution, documented, the best is DS, worst is medical. Safety, let's say 30-day mortality, I'll give to medical therapy, not long-term mortality, but 30-day. And I'll even say DS is the worst. Late complications, I'll give medicine the bad mark of 5 because all of their diseases progress. But DS number 1. Cost, certainly medicine would get a 5 in the long run, but I'd give DS a 4. Life expectancy, again DS 1. So if you look at the total, DS has the lowest score and has 6 out of 8 categories. It's ranked number 1. So if you look at, when I asked the first question, is it the best operation, best for what? And this is breaking it down. Now, this is a paper that we have in press, and I just want to show you some of the findings. We compared the duodenal switch, the adjustable gastric band, medical management to a baseline, namely gastric bypass. How do these things compare to gastric bypass? And this is comparing medical management before, after therapy, and you can see gastric bypass, nice drop in weight, medical therapy, nothing. Gastric bypass, percent weight changes, medical therapy, essentially nothing. Hemoglobin A1C, gastric bypass, yes, medical therapy, no. Use of medication scores, gastric bypass down, medical therapy up. Now you compare it to adjustable gastric banding. Again, gastric bypass wins in all categories with respect to these factors. But now let's look at gastric bypass versus duodenal switch. The gastric bypass does not quite have the weight loss, not quite change in weight, not quite the drop in hemoglobin A1C, and not quite the reduction in medication. So in all four categories, the duodenal switch comes up better than the gastric bypass. So in conclusion, I would say that biliopancreatic diversion and duodenal switch are the near-perfect metabolic operations. Why then are they underutilized and underappreciated? My thoughts: they are difficult to perform. They take considerable operating room time. In the community, they have a higher mortality and morbidity than other metabolic bariatric operations, and they are insufficiently reimbursed for the time and risk involved. Many surgeons can do several bands in time to go to the bank and deposit the money before they can finish one biliopancreatic diversion duodenal switch. And I do think that influences what happens in terms of popularity. But in conclusion, I would say biliopancreatic diversion are the best metabolic operations with one caveat. They are difficult and long procedures, open or laparoscopic, should only be done by trained metabolic bariatric surgeons, and then only really by the best of them. Because if this procedure is attempted by your routine surgeon who isn't familiar with metabolic bariatric surgery or just does bands, they're going to have a higher complication rate. It is not easy surgery, it is difficult surgery, and it should not be done by everyone. So the best reason I can come up with that everybody isn't doing duodenal switches and biliopancreatic diversions is that everybody should not be doing it. Thank you very much.